We're now moving on to Lauren Bauer. She's going to present Mission Possible, Managing Type 2 Diabetes in Kids. Lauren Bauer is a board-certified nurse practitioner at Norton Children's Endocrinology and is affiliated with the University of Louisville School of Medicine. She's a certified clinical research coordinator where she integrates evidence-based care with family-centered strategies. Her work focuses on pediatric obesity prevention through clinical care, education, and community outreach. Thank you, Lauren.
Thank you, and good morning. Today, I'll be discussing the management of type 2 diabetes in kids. This is one of my favorite topics because I have the fortunate role of having dual responsibilities in the pediatric endocrine clinic. Not only do I see and treat patients, I also have been able to continue to use my previous experience as a clinical research coordinator to conduct clinical research studying medications to treat type 2 diabetes. I've personally been a part of trials that led to the approval of some of the medications that we will be discussing today. And so I find this topic interesting and also encouraging because we are able to provide additional options such as the ones we'll be discussing today, as it wasn't too long ago that our only options to treat type 2 diabetes in kids was metformin and insulin. So we'll review our objectives for today. First, we'll start off with reviewing the ADA guidelines related to treatment of type 2 diabetes in pediatrics. We'll outline the goals of care, review the current treatment options, discuss the safety, monitoring, and patient education around those options, and explore some emerging therapies that are on their way. Type 2 diabetes in the pediatric population has been a rising incidence since the early 2000s. While the mean diagnosis age is between 13 and 15 years old, we have seen this develop in much younger patients. Development of type 2 diabetes at a young age can further increase their risk of complication as adults. Pediatric patients can exhibit some differences than their adult counterparts. For example, pediatric patients can have greater insulin resistance and a faster beta cell decline. Factors such as obesity, puberty, genetics, and environmental variables can influence the response to glucose metabolism as well as insulin resistance. These differences in pathophysiology can then drive earlier pharmacologic intervention. Reviewing the ADA guidelines, I want to emphasize two main goals that stood out to me. First, we should consider setting a target goal of less than 6.5% for patients that have a low risk of hypoglycemia. Second, we should provide additional focus to the prevention or management of diabetes complications. While an A1C of 6.5% or lower seems stringent, this could be valuable in lowering the risk of diabetes complications in the future. This goal may not be indicated for every patient. Therefore, it's important to individualize these goals based on the patient's clinical picture. So what is our treatment pathway? For every new onset diabetes patient where we have a clinical suspicion of type 2 diabetes, it is suggested to follow this algorithm. As you can see, it breaks down treatment pathways based on the initial presentation and A1C. You will also note that all patients must be screened for pancreatic antibodies, as we cannot assume a patient has type 2 diabetes based on the factors such as body habitus any longer. We also know that DKA can occur in approximately 11% of pediatric patients with type 2 diabetes, thus again proving that antibody testing is critical. Taking a closer look at the steps in the algorithm, when a patient is initially diagnosed, there's a heavy focus on lifestyle modification. This is critical because we cannot manage type 2 diabetes without diet and activity changes. Our next step in the process is typically initiation of metformin if their A1C is less than 8.5%. However, if the A1C is greater than 8.5%, additional therapies are required, such as insulin. When starting metformin, I typically like to review the way it works with my patients and their families. By doing so, this proves further understanding and value of why we recommend this medication and how it is helpful in managing their condition. This medication works by decreasing the release of glucose from the liver and improving insulin sensitivity. It has been approved for use in pediatrics since the year 2000. This oral medication is started at 500 milligrams once a day and then titrated typically every week up to 2,000 milligrams daily. We counsel patients on the potential side effects that are usually GI in nature. I also like to remind patients to take this medication after a meal to help avoid these side effects. If using metformin and lifestyle modifications still do not get us to our glycemic target, or if it is contraindicated or not tolerated, then we need to move on to our next option. And sometimes that next option is insulin, depending on our A1C. It is also our option if the patient is in DKA. And so we will use this until the acidosis resolves. While insulin certainly has its place in managing type 2 diabetes, ultimately, it's my goal to help patients achieve A1C targets off insulin therapy. The ADA has created a nice stepwise approach if we do not reach our A1C targets. So if the A1C is still above target on metformin and basal insulin, for example, we consider adding an additional agent. In this case, the next step would be to add a GLP-1 agonist. Then, if that medication isn't tolerated or it's contraindicated, a SGLT2 should be considered. If we still have inadequate control, then we need to go back and intensify our insulin regimen. GLP-1 agonists provide a multifactorial benefit to the overall disease process of type 2 diabetes. Their main function helps to improve insulin sensitivity while reducing appetite that may help improve body weight. The medication also helps decrease the release of glucagon from the liver. In addition, there has been some evidence showing improvement in hepatic function, blood pressure, and improved lipid profiles. The first GLP-1 to be approved in pediatrics was liraglutide. This approval came in 2019 after a phase 3 study comparing liraglutide and metformin to metformin and placebo showed clinical significance in reducing hemoglobin A1Cs. This is a subcutaneous injection with a starting dose of 0.6 milligrams daily. It can be titrated up weekly to a max dose of 1.8 milligrams daily. Patients should be aware of the potential for GI upset with this medication. Exenatide was our first once-weekly GLP-1 agonist that was approved in July 2021. This approval came after a phase 3 placebo-controlled trial was conducted where patients were on stable treatment of either diet and exercise, metformin alone, or insulin therapy. Exenatide or placebo was then added to their treatment plan. A reduction in A1C was noted in the treatment arm, thus showing clinical significance. The dosing for exenatide is 2 milligrams subcutaneous weekly. There's no titration involved. However, this could also be seen as a disadvantage for this medication. In May 2022, dulaglutide was approved as another once-weekly medication. Dulaglutide in pediatrics has been approved at a starting dose of 0.75 milligrams sub-Q weekly. The dose can then be titrated up after 4 weeks to 1.5 milligrams weekly. This would be done in order to lower A1C further if needed. What is particularly nice about dulaglutide is that it comes as an auto-injector pen. The dose is preloaded and the patient doesn't have to visualize the needle, which can also be helpful in kids. Once they depress the button, the pen automatically injects the medication and then the patient disposes the pen and grabs a new one the same time the following week. Overall, GLP-1 agonists can provide benefits as well as potential side effects. In addition to A1C improvement and weight loss, we can also see a potential for increased compliance with these medications compared to MDI. Hypoglycemia risk is lower in general, but may be increased with patients that are using insulin. And as far as potential side effects, generally GI upset is the #1 complaint, but some patients may also report injection site reactions or pain. Pancreatitis is a possibility, but is pretty rare, and medullary thyroid carcinoma is listed as a black box warning for this class of medications. However, it should be noted that this has only been reported in the mouse models during the early clinical trial phases. Moving forward in our stepwise approach to treat type 2 diabetes in kids, the use of SGLT2s are now available as treatment options. These are also approved for 10 years of age and older. This medication works by blocking the reuptake of glucose into the kidney. This will then promote glucose to be excreted in the urine and lower blood glucose levels. The overall risk in this class of medication is typically associated with urinary tract infections or yeast infections. Empagliflozin got its approval in June 2023. This was based on the results of the Dynamo study, where patients were randomized to take either empagliflozin, linagliptin, or placebo daily for 26 weeks. Those that were in the empagliflozin group who failed to achieve A1C of less than 7% by the week 12 were further randomized to continue on the 10 milligram dose daily or to increase to the 25 milligram dose daily, which is our 2 dosing options that we have today. Since this is an oral medication, this can be an attractive option for many of our pediatric patients who do not want to take an injection or who do not tolerate metformin or a GLP-1. At the same time empagliflozin was approved, the first combo pill also got its approval. Empagliflozin combined with metformin is now an option as well. However, there are some challenges that can be associated with combination pills in pediatrics. Insurance approval tends to be one of those issues, as well as the uncertainty of drug tolerability of the individual agents. In June 2024, thanks to the T2Now study, dapagliflozin was approved as an additional treatment option. In the study, dapagliflozin was compared to saxagliptin, a DPP-4 inhibitor. Dapagliflozin, but not saxagliptin, showed significant improvement in A1C compared with the placebo. The dose for this medication comes as 5 milligrams or 10 milligrams daily. And this medication can also be particularly helpful in managing patients that might have additional complications such as chronic kidney disease, given its additional approval in adults. Canagliflozin is the newest SGLT2 inhibitor to hit the pediatric market. Dosing is approved as 100 milligrams or 300 milligrams daily. It's ideal to take this medication before the first meal of the day. Hypoglycemia, when used in concomitant with insulin, occurred in about 12% of the study participants. Patients and families should be counseled on this if they are using insulin as an adjunct therapy. So let's say you've achieved your A1C target in your pediatric patient with type 2 diabetes. Now what? Well, ideally, patients that are still on insulin with additional therapies involved, such as GLP-1s or SGLT2s, should have their insulin doses tapered down. We can do this over a period of 2 to 6 weeks by decreasing the dose 10 to 30% every few days while monitoring their glucose levels. Something I found interesting in reviewing the clinical trial data for this presentation, many of the trials studied GLP-1s or SGLT2s, and they did so in comparison to DPP-4 inhibitors. What most of the clinical trial data showed was that DPP-4 inhibitors did not provide clinical significance reductions in A1Cs in comparison to the other drug classes. While this class, the DPP-4 inhibitors, is approved and utilized in adults, we still need more information for pediatrics and possibly additional studies. And just as an aside, TZDs are generally not recommended for pediatric patients due to their side effect profile, and we also have better alternative options. Having different alternatives other than metformin and insulin has opened up a wide variety of options for our pediatric population in order to personalize treatment and manage type 2 diabetes in a more effective manner. Combining metformin with a GLP-1 or an SGLT2 provides an opportunity for patients to have improved compliance and overall control without having to initiate insulin in many cases. Prevention and management of disease complications was one of the goals identified by the ADA guidelines. I like how these are depicted here because it shows a comprehensive review each time we follow up with a patient. It also emphasizes the many different complications that can be associated with type 2 diabetes and the importance of screening. Specific guidelines have been set to screen for these potential complications. In addition to the labs and the vitals, I want to emphasize that we should not forget about the psychosocial implications that this can have on an individual. Thus, having a comprehensive support system that includes a patient's family, along with the multidisciplinary team approach, is highly important for their success. Now let's talk about what's next. This is probably the clinical trial that I'm most excited about for our pediatric population. The Surpass Peds study was a 52-week study looking at the efficacy and safety of tirzepatide in children and adolescents with type 2 diabetes. This was a randomized, double-blind, placebo-controlled phase 3 trial. The results were just published in The Lancet just last month, and I have listed some of the most significant results of the study here, where we saw A1Cs drop by 2.1 and 2.3% in their respective tirzepatide groups of 5 milligrams and 10 milligrams dosing weekly. Weight was also decreased by 8% and nearly 14% in these groups as well. And what you see in the graph above is the effect on A1C, where over 80% of the participants reached an A1C of less than 7% by week 52, and over 50% of the participants reached an A1C of less than 5.7 by week 52. We expect this medication to go under review in 2026 by the FDA for pediatric approval, since it's already being used in adults. Another exciting study was the Pioneer Teen study, looking at the efficacy and safety for the first oral GLP-1. As you may recall, semaglutide was initially approved as a weekly injection for adults and now has been formulated to a once daily oral pill. Our research institute was a site for subject participation, and enrollment for this study closed earlier this year, so we are waiting the results of the trial. FDA application should be following this, and we hope that it will be approved for pediatrics as it's already being used for adults. A different option I thought I would throw in here is the start of a pediatric PK trial for a weekly basal insulin called icodec. Icodec is a novel, ultra long-acting basal insulin analog designed for once weekly subcutaneous injection. Phase 1 studies have been completed, and we are currently awaiting for the next phases to begin. Additionally, icodec is being studied in patients with type 1 diabetes as a basal insulin option, although the main concern in the adult population has been hypoglycemia. And lastly, the phase 3 study for higher doses of dulaglutide are now underway for the pediatric population. As you may recall, the current dose for this medication are limited to the 0.75 and the 1.5 weekly dose for pediatrics. And now we are investigating the higher doses that have been approved for adults with type 2 diabetes. Safety and efficacy of the 3 and 4.5 milligram doses are being evaluated, in this trial, and we have been fortunate enough to be participating in this trial as well in our research institute, and look forward to the results at the completion of the study. This would help provide even more options for our patients. So I hope you have gained some additional knowledge about managing type 2 diabetes in pediatric patients. It's been my pleasure to share this information with you today, and I will take any questions that you may have.
Lauren, thank you so much. You do have a question in the question box from Dr. Folsom. She says, lovely presentation. Can you share the ages of the participants in the Surpass Peds and Pioneer Teen studies? A two-part, and are these likely the ages the manufacturers will pursue for FDA approval?
Yes, so all of our type 2 studies tend to have an age group between 10 and 17 years of age. And so I do expect that these will be the age groups that will be pursued for FDA approval. And so again, it's going to give us some additional options in the future.
Lauren, if you're shaking your crystal ball, which yours is probably as cloudy as mine, do you think that there's going to come an age in the future where metformin will no longer be first line and we'll be using GLP-1s or other drugs as kind of first line for treatment?
I do think that that's a possibility. I frequently, this is why I mentioned about how I like to explain why metformin works in the body and why it's used in type 2, because I get so much resistance at times where one person had a bad experience, and so they don't want their child to undergo that same experience. And so I feel like it's important to review why, the mechanism of action of this drug and why it's helpful in treatment.
Lauren, thank you.